Premature Ventricular Complexes. Premature ventricular complexes, PVCs, are extra heartbeats that originate from ectopic foci in the ventricles. They occur outside of the normal conduction pathway, resulting in early ventricular depolarization. While often benign, frequent or symptomatic PVCs can indicate or contribute to underlying cardiac dysfunction. Epidemiology. Incidence increases with age, most common in middle-aged adults. More common in men, male-to-female ratio is approximately 2 to 1. Higher prevalence in individuals with coronary artery disease, heart failure, and structural heart disease. Pathophysiology. PVCs are caused by abnormal automaticity or triggered activity from ectopic ventricular foci. These foci may spontaneously depolarize, producing action potentials independent of the SA node. Pathophysiological mechanisms include increased sympathetic tone, myocardial ischemia, or electrolyte imbalances, enhanced automaticity, myocardial scarring or dilation, creation of re-entrant circuits, and ion channel dysfunction, early or delayed after depolarizations in ventricular myocytes. Common triggers include caffeine, alcohol, smoking, illicit drugs, for example cocaine, anxiety or emotional stress, and physical exertion. Although often benign, frequent PVCs may reduce diastolic filling time, leading to decreased cardiac output and symptoms. Symptoms. Many patients are asymptomatic. Palpitations, often described as a skipped beat or an extra beat. Occasionally, patients may report dizziness or chest discomfort if PVCs are frequent. Signs. Irregular pulse may be detected on palpation. Usually no other abnormal findings in otherwise healthy individuals. Investigations. ECG. This can show premature broad QRS complexes, usually over 120 milliseconds, not preceded by a P wave. Compensatory pause often follows. Blood tests. Urea and electrolytes to detect electrolyte abnormalities, for example, hypokalemia and hypomagnesemia. 24-hour Holter monitoring. This can be done to assess the frequency and burden of the ectopic beats. Echocardiogram. These should be considered if PVCs are frequent or the patient has a history of structural heart disease. Complications. Usually benign in structurally normal hearts. In the presence of cardiomyopathy or ectopic burden, may progress to ventricular tachycardia or ventricular fibrillation. Risk of PVC-induced cardiomyopathy if frequent over time. Management. Asymptomatic patients. Reassurance is appropriate for most patients. Provide lifestyle advice, reduce or avoid caffeine, alcohol, smoking, and stimulants. Safety netting advice. Seek medical review if palpitations worsen or if new symptoms arise, for example, syncope, chest pain, or dyspnea. Symptomatic or high-burden PVCs. Beta blockers, first-line pharmacological treatment for symptom control. Anti-arrhythmic medications, for example flecainide and amiodarone, these are reserved for refractory cases or those with underlying cardiac disease. Specialist input is advised due to pro-arrhythmic risk. Catheter ablation. This is considered for patients with high ectopic burden of over 10 to 15% of the total beats, PVC-induced cardiomyopathy, and refractory symptoms despite medical therapy. A referral to cardiology is advised for recurrent or complex arrhythmias, suspicion of structural heart disease, or consideration of ablation. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today